I'm Kyung-wook Kim and working as a GI doctor at Yeongnam University College of Medicine, Daegu, Korea. It's my honor to be here to interview Dr. Uri Ladabaum. He is currently a director of gastrointestinal cancer prevention programs at Stanford University School of Medicine. Nice to meet you, Dr. Ladabaum.
Thank you. Nice to meet you.
And first, thank you for attending APDW 2018 and accepting this interview. In this Congress, I think you are one of the busiest physicians as a chairperson and lecturers. Yesterday, you gave a lecture regarding the quality issues for colorectal cancer screenings. What was the most important point in your lectures?
So first I want to say thank you to the organizers for inviting me. It's my first visit to Korea. I'm learning a lot, and it's a wonderful opportunity. So thank you. In the discussion about quality issues, I tried to cover two main areas. One was to review the issues that we face as clinicians in a larger, more conceptual way. But then I tried to give specific practical tips for practicing doctors for their work in colonoscopy. I think the main message in terms of the large issues are that we have to care as both individuals and as endoscopy units, and there are many dimensions that come into play. I won't review all the details now, but we need to take care of our documentation, processes, good preparation, and so on. And as of now, the most important metric that we have is the adenoma detection rate, although we know that does not capture all of quality, but that is associated with the rate of interval cancer. That is on the detection side. What is much harder to measure is our quality of resection, and I encouraged the attendees to review the various items that are recommended for quality. If we are in a system that provides audit, we should definitely take advantage of that. If not, I think we need to pay attention to what we are doing, and in the end, we need to care about trying to do the right job for our patients.
In addition, you also talked about the adenoma miss rate as a quality indicators in another sessions. Could you please comment something about this for the audience?
Sure. So the question to me was whether we should look at other metrics or whether adenoma detection rate remains the most important one. The main points that I made were that the adenoma detection rate is now validated as a good surrogate marker for the interval colorectal cancer rate, which is difficult to measure for individual doctors. Each one of us, if we are responsible for interval colorectal cancer, it would probably take many years for that to happen, and there's not enough time for feedback for us. The adenoma detection rate we know is associated with that most important outcome, and furthermore, it is also actionable in that we know from the Polish screening program that improvement in adenoma detection rate translated into improvement in interval cancer rate. So that is a good metric. It's not perfect in a variety of ways, so I listed some of the alternatives. People have talked about the number of adenomas per procedure, because finding one every time is not enough. We need to also address multiplicity. Next is the issue of finding the advanced adenomas, and there is not always a correlation between adenoma detection and advanced adenoma detection. One might think there would be, but there isn't always. And clinically, probably the advanced adenomas are more important. Next, we can talk about flat lesions, and then of course the serrated lesions, a totally different type of lesion, where again, the correlation between adenoma detection and serrated detection is not one-to-one. But I made the point that it is difficult to conceive of making a complicated measure that takes all of these things into account without also creating big problems for us in terms of audit. And I'm not sure exactly where the trade-off is. So one additional point was to say that maybe we can also begin by considering a larger breadth of indications in which to count our detection rate, because the strict definition of the adenoma detection rate is in first-time screening. But we're doing subsequent screening, we're doing surveillance, we are doing exams in people who have a fit positive exam. So maybe all of those should contribute to our metric. That needs to be adjusted, however, for the fact that, for instance, after FIT, we must detect more lesions. So there are challenges in developing all of these things. I'm not exactly sure what the next step would be. We know that adenoma detection rate is imperfect. As of now, I don't see a simple additional substitute, but maybe in the future we can think of a composite that measures more of these dimensions. And I also made the point during that presentation that this is all about detection. So the same way that in the other session we talked about the importance of adequate resection, I made that same point. Finally, I think we all need to know what our level of skill is. We have just met, and you mentioned to me that you do ESD. I do not. For people who cannot take care themselves of the more complicated lesions, I think we need to characterize these appropriately and refer to the appropriate person, and not make their job more difficult by attempting resection that is not complete.
Okay. My last question is, which quality indicators for you, which quality indicators are essential for you to decide the surveillance intervals in actual practice?
That's a very good question. I'll take the opportunity to say that Dr. Rodrigo Jover from Spain and others recently led an initiative for the WEO to ask just this question: what do you need to have in order to make a surveillance recommendation? And I'm happy to have been a part of that. I don't think it will surprise you or others that the spirit of all of this is to say that one needs to have a quality colonoscopy. So one needs to reach the cecum, ideally photo documentation of the landmarks, good prep, good examination, and basically confidence to know that you were able to see things well. If that's the case, then hopefully one has found all of the relevant lesions and resected them appropriately, and then you can make surveillance recommendations based on the findings. But if the preparation is not adequate, if the exam is not complete, then we cannot move on to surveillance. We need to first take care of an adequate entry examination.
Thank you, Doctor. I hope that you enjoyed this meeting and the time in South Korea. Thank you.
Thank you very much, and thanks again for the invitation.